Starting a bit later than anticipated, but today's class is on ischemic stroke, just the basics, and our facilitator is Dr. Mativo. This is how we're going to tackle this topic from definition, vascular anatomy and physiology. We're going to classify strokes and the pathophysiology of the same, stroke syndromes and presentation, and touch a bit on non-inflammatory vasculopathy. So, like you all know, ischemic stroke is any abnormality of the brain that results from a pathologic process of the blood vessels, which eventually leads to decreased perfusion, and sudden loss of neurological function is the hallmark of cerebrovascular diseases. The pathological process could be occlusion of the lumen or rupture of the vessel lumen, altered permeability, and increased viscosity. Before we start on strokes, we need to know the homunculus, and that's the homunculus. You can see a big chunk, of it. I think you remember this from undergraduate. So in the midline portion of the motor and sensory area, you have the leg, and then as you come out, the hand occupies a big chunk in the face. So, and then this corresponds to the region supplied by the different arches. So you can see over here, most of the anterior cerebral artery supplies, is the pointer? I don't know how to get the pointer. Huh? Okay, you know how to get the pointer. Okay. Use it. Oh, okay. So, this is anterior cerebral artery. So, lesions in the anterior cerebral artery will present with hemiplegia or hemiparesis that's affecting more of the foot and the leg. And then you see the middle cerebral artery supplies a big chunk of the hand, the face, and the posterior cerebral artery is over here.
The significant thing about this is you can get patients with paraparesis. One. Patients with paraparesis. Why is it significant?
To tell you which part of the
Why is it
brain.
significant? A patient who presents with paraparesis.
It can help to localize the region. Territory.
Yeah, but the most important is parasitic tuberculosis. The presentation with
Bilateral.
So that is why it's so significant. If you have a lesion progressing in the middle aspect, therefore you are actually placed on the lower limbs. Therefore, the paraparesis is not always lower. Not the cervical spine. They also die. Posterior circulation is more supplied to the occipital. The base of that is mainly the
So the vascular anatomy, as you know from the from anatomy, So the origin of the common carotid artery from the innominate artery, that's on the right. Then it splits into the internal carotid and the external carotid, and the internal carotid is what gives the blood supply to the brain, together with the vertebral artery, as you shall see in the circle of wheels.
And the other significance about that slide is when we are requesting for an echo, they should comment on
aortic arch.
That is why they need to comment that. Getting an echo report at aortic artery is correct. Because then we're doing the dissection and the aromatase issues around it. That is a significant part of it.
So the circle of Willis at the base of the brain, you have the two vertebral arteries, joining to form the basilar artery, and the basilar artery gives just at the base, it gives the anterior inferior cerebellar artery, and then at the bifurcation of the basilar artery comes the posterior cerebral artery, and then this join via the posterior communicating artery. And then remember the internal carotid comes also and gives the middle cerebral artery and the anterior cerebral artery. This is the anterior cerebral artery, and then this is the anterior communicating. So this is the circle of Willis. So any lesion or occlusion of any of these arteries will produce specific symptoms, as we shall see moving forward. So this is the internal carotid artery. So once the internal carotid artery comes here, over here, it gives the anterior cerebral artery, and it also gives the middle cerebral artery. And then these are the lenticulostriate arteries, which supplies the deep parts of the brain, including the putamen and globus pallidus, the chordates. And remember, the MCA divides into a superior and an inferior portion. The superior supplies the superior temporal regions and part of the frontal, and then the inferior supplies the inferior portion of the temporal.
What's the significance of circle of Willis?
So collaterals, number one.
Yes, Willis collaterals are
To the brain.
Yes.
Especially if you have an ACA, like an anterior cerebral artery lesion, the patient might not present with a lot of symptoms because of the collaterals from the MCAs and the anterior communicating. So the watershed areas are usually the most vulnerable, and this is where, so this is the ACA territory as we had seen, and then this is the MCA. So the ACA, MCA watershed is the region where there's like minimal blood supply, and they are mostly susceptible to hypoperfusion. And then you get some minimal strokes there. Also the MCA and PCA watershed areas, as you can see.
There is internal and external watershed supply. This is external. It's also internal, the basal ganglia. It's another watershed area.
So, also it's important, and this one we discussed the other day when Janet was presenting the sagittal sinus, the cavernous sinus, and how eventually because these are the venous supply of the brain, then go to the sinuses. So I won't tackle much on this, but it's important to know. So I'll just go to cerebral autoregulation. Usually, cerebral blood flow is maintained constantly despite moderate variations in the perfusion pressure. And although this mechanism of autoregulation is not well understood, it involves multiple pathways, including smooth muscle cells in the cerebral vessels respond quickly, and they contract when pressure increases and relax when pressure drops. So, so reduction in cerebral blood pressure flow may lead to dilation of the blood vessels, and via, you remember, the nitric oxide pathway is one of them. Okay, I need the pointer here.
Second.
No,
Second.
on my screen.
What will you see?
Yeah, it's there, but it's not on my screen. So mean arterial pressure should be maintained between 50 and 150 to maintain cerebral perfusion.
As exactly that, brain is only accounts for 2% of the body, and cardiac output is actually 15%. And then the oxygen utilization is 20% of the body. Therefore, you can see how highly metabolic the requirement is. 15% of cardiac output, 20% of oxygen utilization, and it's only 2% of the total body. Because that's how significant supply should be because of metabolism.
Okay, so like Dr. Matiba said, you need to maintain the mean arterial pressure between 50 to 152 to maintain cerebral blood flow. Now, the effects of decreased. Okay, now it's not moving. Huh? Which screen?
Move it to your right, to your left.
Okay, so a decrease in perfusion pressure of the brain beyond the ability to compensate results in, of course, decreased cerebral blood flow. So initially, oxygen extraction is increased in order to maintain levels, but as the cerebral blood flow continues to fall, other mechanisms come into play. Like number one, you have inhibition of protein synthesis begins. Yeah, when you have the cerebral blood flow reducing to 50 per 100 grams per minute, there's inhibition of protein synthesis. And then when it goes down to 35 per 100 grams, the protein synthesis ceases completely and glucose utilization increases transiently. And then at 25 ml per 100 grams per minute, there's onset of anaerobic glycolysis, and then this leads to accumulation of lactic acid, which leads to acidosis. Now, eventually this leads to neuronal electrical failure, which occurs at about 16 to 18 ml, as you can see there, 16 to 18 ml per gram per minute, and failure of membrane ion homeostasis occurs at 10 to 12 ml per 100 grams per minute, and this level marks the threshold for development of infarct. So when the blood supply is down to 10 to 12 per 100 grams per minute, then there's cell death and eventual infarction. I don't know what's happening. Is it now? Okay. No. I don't know what's happening. It's disturbing me. Resume it. I don't know. It's just refusing to work. Not yet. I need to resume. Until we sort of this thing out.
So just don't move the cursor.
Okay. So classification of stroke. most 80% of them are from brain ischemia, which could be due to thrombosis. Thrombosis could be in the large vessel or small vessel. It could be due to embolism, like cardioembolic strokes. Systemic hypoperfusion and blood disorders like sickle cell disease, polycythemia, essential thrombocytosis, and the other thrombophilias. Brain hemorrhage accounts for about 20%, and it could be intracerebral hemorrhage or subarachnoid hemorrhage. There's a TOST classification of subtypes of acute ischemic stroke, where you have the large artery atherosclerosis, cardioembolism, small vessel occlusion, stroke of other determined etiology, and stroke of undetermined etiology, where you have two or more causes identified, negative evaluation or incomplete evaluation. So the etiologies are many, ranging from systemic hypoperfusion, thrombosis, embolism, and luminal obliteration. And you can see if you start evaluating a patient who presents with stroke, there are so many tests that you can do. Before you name it cryptogenic, there's a lot you can actually do before you say it's idiopathic. So a massive MI can lead to stroke due to hypoperfusion, severe hypotension with proximal stenosis also, and hyperviscosity syndrome, all the way to monogenic disorders like Moya diseases, CADASIL, CARASIL, and fibromuscular dysplasia. All these can cause strokes. We have a gentleman in the world who has fibromuscular dysplasia. He had a vertebral artery dissection. It's a good case. These are high-risk sources for cardiac emboli. You can see the list is too long, from left atrial thrombus all the way to arterial dissection, and the low-risk sources like mitral annular calcification to pulmonary arteriovenous malformation. Variable risk sources could be a hypercoagulable state, cancer, antiphospholipid antibodies. Vasculitis is also another aspect. It could be inflammatory, either primary, secondary, primary angiitis of the CNS, secondary from large arteries, which we've talked about before, so the giant cell arteritis, Takayasu arteritis, to the medium vessel, small vessel, and the one that affects the microcirculation, like vessels and Sjogren's. Infections, HIV, hepatitis, all that can cause due to vasculitis in the blood vessel, and also bacteria. You can see Neisseria, all the way to protozoa. Malaria can cause cerebral vasculitis. The genetics of ischemic strokes, like the monogenic disorders like Marfan's, CADASIL, CARASIL. CADASIL is. Does anyone know what CADASIL is before I start rushing through? Anyone? Okay, so CADASIL is cerebral autosomal dominant arteriopathy with leukoencephalopathy. And autosomal dominant, that means it runs in families. The patient will present CADASIL, they present with migraine with aura. So the patients will come in with migraine with aura, then they will also have frequent TIAs or strokes, and also present with neuropsychiatric manifestations. And the gene you test for, it's called the NOTCH3 gene, which is found in chromosome 19, and there is no treatment. You just control other secondary factors like hypertension. Now, CADASIL is just the opposite, it's autosomal recessive. I don't know, are these really important, Dr. Matiba?
I've seen a patient who you're not going to practice in one occasion. The mother had stroke, and mother had stroke.
Yeah.
She was in the camp, she was in the mass December. Even investigated for launch. that not gene.
Hmm.
Therefore,
It's important. Like
they are
if,
living in a village.
and it's mostly in the Asian communities, but you can also find maybe. I've never seen a Kenyan with it, but then again, I've never tested. So maybe those patients that we label idiopathic stroke in the young, maybe they have cardiac. Fabry's disease is an X-linked lysosomal storage disorder. It also manifests with acroparesthesias, where you have paresthesias in the lower limbs. You have hypohidrosis, corneal dystrophy, and cardiac conduction diseases. So these monogenic disorders, most of them are multisystemic, and even if they present with brain symptoms like strokes, then you also have to evaluate other systems. Like in Fabry's, you need to do an ECG to look for arrhythmias in case of conduction deficits. Which is the other one? Sickle cell disease, we all know how it can cause ischemic strokes and the genetics of the same. What are the genetic issues in sickle cell disease? Hello. What happens in sickle cell disease?
It's from some 11 days replacement of glutamic or glutamic acid provided on the
Which position?
6th quadrant.
So pathophysiology of strokes or ischemic strokes and what happens eventually leading to infarction. Larry, you want to take us through?
Okay, so essentially there is the blockage of circulation or hypoperfusion due to either systemic or due to focal blockage of a vessel. So the first step is that as we saw those thresholds for flow, below a certain threshold, we start getting energy failure. Essentially, the most energy dependent unit in the cell, which is the sodium potassium ATPase pump, starts failing. And at that point, you start repolarizing the cell. So the cell becomes more permeable to both sodium and calcium. So with that, you have two pathways that are activated, both leading to cell death. There is a necrotic pathway as well as the apoptotic pathway. So the necrotic pathway is activated by essentially the high intracellular calcium, as well as the breakage of most membranes, including lysosomal membranes. So calcium causes an excitotoxic cell death, which it activates a lot of glutamate release. So there's in the umbra region you have excessive depolarization, which causes more and a cascade of calcium production. The other pathway is that you have activation of calcium also activates phosphatases and the like, which break down cell membranes even further, which also releases the enzymes also. For the apoptotic pathway, usually happens in the penumbra region. This is cells detecting that they don't have enough resources to survive, so they start activating the apoptotic pathway. There is also activation of the other inflammatory pathways, the COX, the indicible NOS, as well as the infiltration by leukocytes in the acute period, which also produces a lot of interleukins, which also affect the cell death pathways. Essentially that's.
So he summarized quite well, and just maybe to add is with glutamate release, there is activation of the NMDA and PA receptors, and the inositol phosphate 3 pathway, which leads to more further calcium release, and the elevation of intracellular calcium, sodium, and chloride This is what leads to activation of kinases, proteases, lipases. All these lead to necrosis. It causes cytotoxic edema, leading to osmotic lysis and eventual necrosis. Activation of endonucleases, calmodulin and calpine, which now are essential in the apoptotic pathway. There's also the function of the lipid peroxidation, could be due to increased NO production, could be because of formation of free radicals, which also lead to cell death, cell membrane disruption, and eventual cell death. So he brought up a point about the umbra and the penumbra, and the reason why we focus a lot on ischemic strokes is so that we save the penumbra. And he talked about apoptosis being the main the main cause of cell death in the penumbra, because apoptosis is energy dependent. It requires ATP, and in the umbra you don't have blood supply; it's infarcted, so there's no energy. So that undergoes necrotic pathway, but apoptotic pathway is in the penumbra. And he's already talked about the neuronal death being via necrosis and apoptosis. And apoptosis, remember, there's the intrinsic and the extrinsic pathway. The extrinsic pathway is via the death receptor. The intrinsic is in the mitochondria. So this, can't see anything. So this is, I will send the slides, but this is just a summary of the intrinsic and the extrinsic pathway. The intrinsic pathway it uses the NMDA, BID, truncated BID. It's really complex. I don't want to go into that. And then the first ligand pathway is the extrinsic pathway. Tatsuki told me to remove this slide. So factors affecting rate and progression will be the rate of onset and the duration of the stroke, collateral circulation, health of the systemic circulation. Like if someone has a thrombus or an occlusion, atherosclerotic occlusion of the say MCM, and then already they are hypotensive, then even the effect of the stroke will be worse. Hematological factors like the coagulation profile, temperature, and glucose metabolism. Hypoglycemia is especially detrimental in patients with stroke, and hypothermia. So we already
Hypothermia is the only.
Hypothermia.
Hypothermia is the only thing we can do today to fight them.
Yes. So hypothermia.
Actually, we need to set up hypothermia in this hospital so that we have time. Because it gives you time. It reduces metabolic rate, that work. It buys time for you to teach the patient. So that's the only way of protecting approach in this world.
So we've talked about the umbra and the penumbra, and we've said the penumbra is the metabolically active and is salvageable, and it's definitely at risk of infarction, and that's why we need to save it. So you've heard about hemorrhagic transformation and patients with ischemic stroke converting into a hemorrhagic transformation. And this is due to, number one, endothelial cell damage due to leukocyte infiltration. And this causes the capillaries to be leaky and causes extravasation of blood. There's also the role of matrix metalloproteinases and blood flow provided by collateral channels to the ischemic core also causes hemorrhagic transformation. There's also a role of hypertension, and that's why in patients with stroke we also try to control their pressure.
And that is the reason why when you try and thrombolyze liquids, already the friable cells are going to be. Therefore, that is where there is a timeline. These are friable cells which are going to open, decrease pressures. Already the tissue is the thread is broken down before you go to having pneumatic transplantation.
So just going to the stroke syndromes, this is what I think was interesting for me. So there's the middle cerebral artery where you have the complete MCA syndrome, the partial MCA syndrome. Anterior cerebral artery, you have A1, A2, and posterior cerebral artery syndrome, so you have P1, P2 syndrome. Vertebral artery, you have the Wellenberg and Dejerine syndrome, and the basilar artery, which is, if affected, you have locked in, and the rest. So we'll just do a bit of clinical scenarios, and Kuka, you can start us off.
So in a 76-year-old right-handed male with sudden onset of difficulty in speaking, which is fluent, with inability to read or name. He also has right-sided weakness, with the arm being more weak than the leg, and so right sensory impairment. The duration was 90 minutes, there's no headache, and the history of coronary artery disease, hypertension, and dyslipidemia. He's been on aspirin. So that this presentation confirmed to a particular stroke syndrome. So he's having evidence of motor weakness. That's a weakness in the arm more than the leg, and also sensory weakness. There's also a history of difficulty speaking, being unfluent. So with the motor involvement, being on the right, thinking the left, if I think of the left MCA, because of the motor involvement, as well as what you think could be involvement with the Broca's head, which should be the frontal aspect of the left hemisphere, him being right-handed, and that means his dominant side is likely left. So the hemisphere affected would be the left, and it would conform to an MCA stroke.
Left MCA.
So because of the
Difficulty in speaking is it talking about slurring of speech, or is talking about expressing?
Non-fluent aphasia. So this patient is right-handed, meaning the dominant side is left. So there you get a global aphasia.
So because of the left.
So they get hemi-anesthesia. So not explain which kind of sensory impairment, but they get hemi-anesthesia on the contralateral side.
And I think the inability to read as well, that shows there's involvement of the angular gyrus, and that is normally close to the post-central gyrus where the sensory cortexes.
So what else would you expect in a patient with a left MCA stroke who's right-handed? Like if you examine, what else would you be looking for? Okay. What else? Some of the yeah. So in terms of vision, what kind of hemianopia do they get? Like in this patient, what do you expect? So they'll get homonymous. Yeah.
And also,
So say this right-handed guy, the stroke was in the right on the right. What is the difference you'd expect in terms of his presentation? They'll have neglect. So they have neglect, hemispatial neglect, if it's in the non-dominant hemisphere. So that's the CT scan of the patient immediately. So what do you see?
There's the left MCA sign.
Okay. I don't want to start messing up with this thing, but you can see a dense MCA sign on the left. Can you see that hyperdense lesion? Please make sure you see it. Can you see it? No. Up there. Show it.
MCA sign.
That one. Dense MCA sign is there. You've seen it. You've seen it. Dense MCA sign. Yeah. So it means this. So that was immediately. Yes. So then that's in the next few days. That's the CT. So what do you see? It's not moving. My God.
Let's move the cursor. Let's move the pointer
to
your right. Make sure you can see the pointer.
Yeah, I can see.
Yes, and then weakness.
There. So that's follow-up CT. Immediately you saw the CT was like that. Then that's. So what can you see? Farah?
So there's a hyperdense area on the left side. There's a bit of occlusion of the lateral ventricles as well.
So is it hyperdense or hypodense?
Hypodense, sorry. Did I say hypodense? And there, okay, I can't tell from where I'm sitting, but it doesn't seem like there's any midline shift.
Okay, so here the important thing I just wanted to show you is initially, when you do a CT scan, you might not see a formed infarct, but then later on you see it if you do not do anything about it.
Usually, there's MCA, this patient was protected.
Yeah.
Okay, but you know, from ISIS, but you still protected. CT scan evolution is 3 days. Before you do a CT scan, doesn't mean there's most about 3 days.
So anterior circulation syndrome, like we've 80% of the strokes will be in the anterior circulation. They present with contralateral hemiplegia and homonymous hemianopia, with contralateral sensory deficit, aphasia, and visual spatial disturbances, which we've seen in that case. So we'll go into this case.
Anterior circulation involves the MCA
and the ACA.
Posterior circulation is
PCA. Yeah. Okay. So case 2, Anthony.
60-year-old male, history of migraine, visual or hypertension, anxiety, presents with the family history of headache.
Sorry, I didn't know that.
This headache started similar to previous migraine headaches. It became more severe than usual. The migraine concerning to double vision, disturbed balance, speech, and so on. The patient was treated in emergency department. The level feels analgesia and discharge of diagnosis of migraine. The following day, the symptoms worsened, clinical exam revealed rheumatic hypertrophy. Gaze evoked jerk disturbance, right side aspirating and transitory.
So
First one, posterior circulation.
So what makes you think of that it's a posterior circulation?
One, the fact that he had disturbed balance, swallow, which was speechless, and then I've now vertical development when it's the first times passport is also the other side.
So would it have been picked up on the first day when he came?
Yeah, exactly.
Okay. So the patient had intermittent double vision, disturbed speech, balance, and swallowing, and was treated for migraines. Indeed, it was a posterior circulation syndrome, which the patient presents with cranial nerve impairment, especially cranial nerve 3, oculomotor. They will present with binocular visual loss with visual hallucinations, and cerebellar dysfunction, as you've seen, vertigo, and hearing loss. So the typical circulation of the PCA supplies the midbrain, the thalamus, the occipital, and the dorsomedial temporal lobe. And the hallmark localizing sign for PCA territory, in fact, is contralateral homonymous hemianopia, which is secondary to occipital lobe infarction. Absence of hemiparesis, patient will not have hemiparesis, or other hemispheric signs that will localize to an MCA. So if you find a patient doesn't have hemiparesis, but they have the contralateral homonymous hemianopia together with the cerebellar signs and vertigo, then you think it's about a posterior circulation syndrome.
So in that case, even total passages likely presents
But
might passages likely it was with the cranial nerve symptoms of ischemic circulation syndrome. Also can present this nephrological
Janet.
So every evening, the 61-year-old man entered the emergency department with sudden onset of bleeding that lasted for 2 hours. The patient's blood pressure, heart rate, respiratory rate, and body temperatures were 40-70. Blood pressure, heart rate of 92, respiratory rate of 16, 6% saturation, and body temperature of 36. His medical history had essential hypertension for 10 years and a right hemiparesis. His physical exam, he had Hunter syndrome, hemiparesis, 4-5 level of the muscle strength increased,
Big tendon reflexes.
big tendon reflexes, Babinski reflex positive, dysmetria, dyskinesia on the right side, and ataxia were present. In observation period in the emergency department, he started to have hiccups. So, visualization. So, blood pressure is okay.
So first of all, which syndrome is this?
It's a one and one.
Okay, so what is a Wellenbach syndrome? It's fine, continue. Yeah. So tell us why does the patient have Hunter syndrome?
So it is the lateral medullary syndrome. So you have a stroke within the medulla.
Okay.
We have it's like just one side. So on the affected side, you expect, so it's occurs in the affected side, you expect contralateral loss of sensation and temperature from the lower extremities. You expect it's the lateral loss of pain and temperature on this same side as the cranial nerve distribution on the face. You expect for ipsilateral cerebellar symptoms, which has splenogenesis and ataxia on the right side. And there's also a decussation of the cranial, of the motor tracts. So you expect so he has been having spasticity and increased reflexes.
Anything else? Why is the patient having? They have this. Why do they get dysphagia?
So the
9 and 10.
the Hunter syndrome because of the
Sympathetic tract. So that would be ipsilateral. Maybe you're talking about Hunter's and what's Hunter's syndrome? Medical student. Yeah. Okay. Then what's Hunter's syndrome?
Hunter syndrome is a triad for ptosis, meiosis, and hydrosis, which is half growth. a lack of sweat inflation. It's with disruption of the sympathetic fibers. In this case, this guy will get a Horner syndrome because the descending fibers, their fibers are just on the lateral side of the middle.
Okay.
They are accompanying
So they will present with ipsilateral loss of pain, numbness on that side of the face, ipsilateral. That's due to cranial nerve 5. Yeah, and then they'll present with ataxia. Ataxia could be because of the involvement of the vestibular nucleus and also the restiform body. They'll present with nystagmus, diplopia, vertigo due to vestibular nucleus involvement, the dysphagia, hoarseness, paralysis of the palate, vocal cord paralysis due to cranial nerve 9 and 10, and then loss of taste due to nucleus of tractus solitarius, and then numbness of the ipsilateral arm, trunk, and leg due to the cuneate and gracilis nuclear involvement. Horner syndrome we've talked about. Weakness of the lower face due to the involvement of the upper motor neuron fibers supplying the ipsilateral facial nucleus. And eventually, contralaterally, they'll have impaired pain and temperature over half of the body. This is due to involvement of the spinal thalamic tract. So that is what lateral medullary syndrome is. So this is the MRI of this patient, and can you see anything? So the symptoms are on the right. Can you see anything? Hypodense or hyperdense? This is MRI. You can see it. You can't see anything. Where is the medulla? First of all, yes, there it is. You can see it now. There. Lateral medullary syndrome. And lateral medullary syndrome can occur when you have involvement of the either vertebral, the picas, the superior inferior medullary arteries. So there's the medial and lateral medullary syndrome. And who can tell us what medial medullary syndrome, what the patients will present with? So I can tell you that the pink, this is where the medial medullary syndrome is, and then is it blue? That's where the lateral medullary syndrome is. So if you just look at it, a patient with medial medullary syndrome, what will they present with? You can see there's involvement of the pyramidal tract, and then there's the 12th nerve. So what will this patient come with?
And then we will come to cranial nerve 12.
Okay, so cranial nerve 12, they have what? Okay. The paralysis of the tongue, yeah? One half of the tongue. That is because of the 12th nerve. Then the pyramids, then they'll have contralateral paralysis of the arm and leg, and the impaired tactile and proprioception in one half of the body. So that is medial medullary, but most of the time we pay more attention to the lateral medullary syndrome because it has more. So if you look at this, then you will see why they get what they get. You can see this is where they okay. It's lost.
Which of the errors will you take your content?
Separate strings. Okay. So, like I was saying, so for the lateral medullary syndrome, you have the descending sympathetic tract, which is, you can see over here. So you get the Horner syndrome. the restiform body. If affected, you get the ataxia. Then you have the descending nucleus and tract of the fifth nerve, and that's where they get the ipsilateral numbness of the face. Tractus solitarius with the nucleus, that's taste. And the spinothalamic tract, that's what we've talked about, the contralateral loss of pain and temperature. So these are some of the common brainstem stroke syndromes, from Weber to Benedict. Those are just names of the people who discovered it, but it's important to know that they have cranial nerve involvement, especially in the Webers, the Benedict, and the Nagel. We've talked about the Wellenberg. The Gerine, I think here the most important one to know is the Wellenberg and the medial medullary syndrome, which we've also talked about.
Linda. 65-year-old male with a medical history of hypertension presented with symptoms of dysarthria and numbness in his right hand, which had abruptly started 6 hours prior to admission. A neurological examination showed cerebellar dysarthria, mild paralysis in his right upper and lower limbs, prominent in the distal upper limb. Medical research MRC S grade 4 out of 5, and right-sided dysmetria. Other examinations, including sensory and cranial nerve examinations, were normal.
What is the lesion?
So there is weakness, predominantly in the right hand, but he also has some cerebellar signs.
Clumsiness.
Paralysis, yeah, or is out of 5.
Yeah,
Not much. Okay.
But what's the prominent thing?
The prominent thing is the, I think it's the cerebellar.
The dysarthria and clumsiness on the right hand.
So, I think it's about coordination. I'm not sure.
Any other thoughts? Janet?
I think it's to do with coordination.
Who can say?
Cerebellar syncope. Dysarthria, the was pointing, and sensory and cranial nerve exams are normal.
Okay. So yeah, so the cerebellar and clumsiness.
Clumsiness is because the role of the cerebellum is to fine-tune the movement center.
Okay. So what syndrome do you think is this?
I think it's still broadly posterior circulation. But now,
So that's the MRI, and that's where the lesion is. It's in the paramedian rostral pons. The pons. Can't see?
When the
Yes. So that was the upper one is the DWI, where you see there's hyper intense lesion in the rostral pons.
so but pontine branches initially from the basilar artery.
What?
Pontine branches.
Yeah.
From the basilar
So
artery.
it's still posterior circulation, but in the pons, not. So anyway, so this is a lacunar syndrome, and of this lacunar syndrome, this is the dysarthria clumsy hand syndrome. So there's lacuna syndromes. You have the pure motor, pure sensory motor, dysarthria, clumsy hand, ataxic hemiparesis, and hemipalismus or hemicoria syndrome. And this just depends on which part. So lacuna syndromes, you know, the involvement of which arteries? Lenticular striates, yes, which have their origin either from NCA or from the PCA. So pure motor is so they present with contralesional hemiparesis, and this is due to the involvement of the posterior limb of the internal capsule. Remember, that's where the fibers that supply the fibers of the which tract. Corticospinal. Yes, they pass in the posterior limb. So lenticular striate branches of the MCA or the perforating arteries from the basilar artery. Pure sensory, they'll have contralateral sensory loss, and this is due to involvement of the ventroposterolateral nucleus of the thalamus. And of course, the supply is NCA, lenticular striate, and the small thalamo perforated from the PCA. So the dysarthria clumsy hand that you see, they'll present with slurred speech and typically fine motor weakness of the contralateral hand. And it's at the base of the pons, between the rostral 1/3 and the caudal 2/3. And it supplies the perforating arteries from the basilar artery. Some of them come with ataxic hemiparesis, which is there's contralateral hemiparesis and limb ataxia out of proportion of the degree of weakness. And again, it's the posterior limb of the internal capsule or the base of the pons. The hemipalismus or hemicoria is a contralesional limb flailing or dyskinesia, and it's in the subthalamic nucleus, again, the perforating lenticular striate arteries. So it's important to note this because it mostly occurs in patients with hypertension, and the pathophysiology of which is known, but the patients will not present classically with MCA or PCA, but they come with the lacuna syndrome, one of them. So TIA is also another entity in strokes where there's brief episode of neurologic dysfunction resulting from focal temporary cerebral ischemia that is not associated with cerebral infarction. So the pathophysiologic mechanisms, you could have large artery low flow, TIA, which is a true TIA, short-lived, and it could be recurrent. Embolic, which can last hours. Lacuna, which is brief, recurrent, and there's a risk stratification of TIAs. And I think we've heard about the ABCD2 score, which I'm not going to go into, but we'll look at it after this. You tell us about the ABCD2 score and what is the importance of ABCD2 score.
So,
what does A stand for?
So it's a criteria to evaluate patients who need admission and patients who are at high risk of
developing a stroke in the next 48 hours.
So ABCD, A is for age, include more than 60. B is for blood pressure, and C is for the clinical presentation. So if someone presented the TA like one-sided weakness, that's a score of 2. If they present with the speech disturbance, that's a score of 1. And then for the, let's see, D, 2 of them is the duration of the symptoms. It's more than 60 minutes, that's a score of 2. More than 60 minutes, that's another score. The second D is patients who are diabetic. So, I mean, if you stratify, I think you get a score of more than 3. That means they're at high risk, and they need admission for evaluation.
Okay. So there are stroke mimics. The patient comes into casualty with a seizure. It could mimic a stroke. A seizure can also occur in the context of a stroke. And then the clinical aspects to differentiate from a stroke, I'm sure that one you know. Witness, seizure activity, post-ictal period, direction of gaze preference, and the history of seizures. Maybe they're already epileptic. Metabolic encephalopathy like hypoglycemia, hepatic renal encephalopathy could mimic, same as toxic encephalopathy and other infectious encephalopathies. A brain tumor, especially one, although this would have a gradual onset of symptoms, not unless there is intratumoral hemorrhage, of which now they will present with sudden onset of symptoms. Neuromuscular disorders will also present with focal weakness and numbness. Migraine with aura can also can mimic strokes, and of course, psychogenic. So red flags concerning for central process if a patient comes with acute vestibular syndrome. This one I cannot overemphasize. If a patient comes with vertigo or dizziness, you need to make sure there is no central cause of the same. And you know about the hints, which we discussed severally. On top of that, they have focal signs like dysmetra, dyssynergia, and dysdiadokinesia, together with acute neck or occipital pain, which could signify vertebral arch dissection. And in a high-risk patient, diabetes, older patient, history of prior strokes, those are patients that you really need to evaluate. So in summary, for a stroke, yes, it's good to know the stroke syndrome and to know that this is MCA, but you need to actually recognize that this is a stroke before you say it's MCA or PCA. So that can be, our aim here is to recognize that it's a stroke and be able to revascularize in time and be able to differentiate between ischemic and hemorrhagic strokes. And on top of that, take a good and detailed history, because if there is a secondary cause, then it's important to deal with it before they get recurrence. So that's the end of my presentation. Any questions?